Hello everyone and welcome! Today we're going to talk about something you will see in your clinic literally every single day. I'm talking about drugs for cough and bronchial asthma. Trust me, mastering this topic is absolutely crucial for treating your patients well. So, let's just get started, shall we?
You know, every patient will come and ask, Dr. Saab, which cough syrup is the best? And when you look at the chemist shelf, my God, there are hundreds of them. But have you ever really stopped to think about what's actually in them? Or are they all just the same thing in a different bottle? And here's the big question. Do they even work? Let's find out.
Okay, so here's the plan for today. First, we'll spend some time decoding these cough syrups. Then, we'll get into the real story of what asthma is. After that, we'll open up our bronchodilator toolkit. We'll also talk about something I call Theophile's tightrope walk. You'll see what I mean. And finally, we'll wrap it all up with how to write a rational prescription. Ready? Jello, let's begin.
All right, first up, decoding cough syrups. Let's really look inside that bottle, you know? A cough syrup, it's not just some sweet, sugary liquid to make your throat feel good. No, it's often a whole cocktail of pretty powerful drugs. And to use them properly, or more importantly, to know when not to use them, we really need to get what each ingredient is actually doing.
So, inside most of these syrups, you're going to find four main characters. First, you've got your antitussives. These are for that dry, hacking, irritating cough, you know, the one that produces nothing. Then, you'll find first-gen antihistamines. Their job, mostly to make you a little sleepy and to dry things up. Next, you have bronchodilators. These are for when the cough comes with a wheeze or bronchospasm. And expectorants. Well, we'll skip talking about those for today.
Okay, now, I want everyone to look at the screen very, very carefully. This one sentence, you need to burn it into your brain. This is probably one of the most important things you'll learn today. The vast majority of these fixed-dose combination, or FDC, cough syrups, you know, the ones you see in all the ads, are pharmacologically irrational. Basically, they make no sense. Whatever effect they have, it's often just a placebo. Understanding this is the foundation of being a good doctor.
So you might ask, why are they irrational? What's the problem? Well, let's break it down. Think about it. You're mixing an antitussive with a bronchodilator. They work for different amounts of time. So one drug stops working while the other is still going. It's just illogical, right? And what about adding an antihistamine? Its whole job is to dry up secretions. But if a patient has a productive cough, you want to get that mucus out. Drying it up just makes it thicker and harder to cough up. And please remember this, there is zero proof that these work in asthma.
All right, let's shift gears. We're moving from just a symptom, a cough, to a whole disease, bronchial asthma. And the number one thing I need you to understand is this. Asthma is not just a simple spasm. It's not just the airways tightening up for a moment. No. The real villain here, the root cause of everything, is inflammation, a long-term chronic inflammation. So this definition right here, this is the whole story of asthma in a nutshell. Look at the key words. First, chronic inflammatory. It's always there, this low-grade fire. This fire makes the airways hyper-responsive. What does that mean? It means they overreact to everything. A little bit of dust, some cold air, and bam, they clamp down. This leads to reversible airway obstruction. And that word reversible, that's the golden word for us. It means we can fix it. It's why our drugs are so effective.
Okay, look at this. This flowchart is basically our battle plan against asthma. It's got two main arms of attack. On one side, you've got the bronchodilators. These are your emergency relief troops. They go in fast and open up the airways right now. On the other side, you have the anti-inflammatory drugs. These guys are not for immediate relief, but they are fighting the actual war. They're putting out that inflammation we talked about. So let's take a closer look at our weapons.
All right, Section 3, the bronchodilator toolkit. These are the drugs that literally open up the airways. They're your frontline defense, the ones that give that immediate, sometimes life-saving relief. And the king of this toolkit, the most important class by far, is the beta-2 agonists.
So how do these things actually work? It's really quite simple and elegant. Just imagine a beta-2 receptor on the muscle of your airway. Think of it like a switch. The drug, say salbutamol, comes along and just flips that switch on. What happens next? Inside the cell, a messenger molecule called cNAMP starts getting produced. And cNAMP's only job is to tell that muscle, relax. So the muscle relaxes and poof, the airway opens up. It's as simple as that.
Okay, but not all beta-2 agonists are identical. We split them into two main teams.
First, you have the SABAs, the short-acting ones like salbutamol. These are your relievers, your rescue inhaler. You use them when you're having an attack for fast relief. Then you have the LABAs, the long-acting ones like salmeterol. These are the controllers. They're not for an attack. You take them every day to prevent attacks from happening. Relievers versus controllers. Simple.
Now, this next point is absolutely critical. I mean, life-saving critical. You must never, ever prescribe a long-acting beta agonist, a LABA, by itself for asthma. Why? Because if you only use a LABA, you're just opening the airways. You're masking the problem. But that fire, that inflammation we talked about, it's still burning underneath. So the absolute rule, the law you must never break, is this. A LABA must always be given with an inhaled steroid.
Okay, on to our next section. We're going to talk about an older group of drugs now, the methylxanthines. And specifically, we're going to focus on one drug, theophylline. And let me tell you, using this drug is not easy. It's like walking a very, very thin tightrope.
This graph shows you exactly what I mean by a tightrope. See that tiny little green zone? That's the therapeutic window. That's the only place where the drug actually works safely. If your patient's blood level is just a little below it, the drug does nothing. If it goes just a fraction above it, you are immediately in the red toxic zone. And we're talking about serious toxicity here, from nausea all the way to seizures and even death. It's an incredibly fine line. So what's the bottom line? Theophylline has a dangerously narrow margin of safety. Its toxicity can hit the central nervous system, causing things like seizures, which is especially scary in children. It can mess with the heart, causing arrhythmias. It can irritate the stomach badly. And to top it all off, it interacts with tons of other drugs. All of these dangers together, that's exactly why we don't use it as a first-choice drug for asthma anymore.
Okay, so we've talked about what's wrong with most cough syrups. We've seen the dangers of older drugs like theophylline. Now, in our final section, let's put it all together. Let's talk about the right way to prescribe, how to choose the right tool for the job.
Now, this is a really smart combination, and this picture shows why. The red dots, those are the beta-2 receptors that salbutamol targets. See how they're mostly in the smaller outer airways? Now look at the blue dots. Those are the M3 receptors that anticholinergics like ipratropium block. They're concentrated in the bigger central airways. So by using both drugs together, you're getting a beautiful two-pronged attack, hitting the problem from two different places with two different mechanisms. Very effective.
So when do you use which one? Well, for asthma, the beta-2 agonists are still the best. They're faster and more potent. But for COPD, that's where the anticholinergics really shine. Why? Because in COPD, a big part of the problem is something called high vagal tone. Basically, there's a nerve that's constantly telling the airways to tighten up. And anticholinergics block that signal directly. So they are the bronchodilators of choice for COPD.
And finally, we come to what is, without a doubt, the most important part of treating asthma today, the anti-inflammatory drugs. Remember, bronchodilators are for rescue, but these drugs are the foundation of your treatment. Corticosteroids, especially inhaled ones, are the #1 choice. They are the ones that actually put out the fire. Then you have drugs like montelukast. These are great for prevention, especially in milder asthma, and mast cell stabilizers. You won't see them much anymore, but it's good to know they exist.
So that's a wrap. We've seen why so many cough syrups just don't make sense. And we've built a really solid, logical toolkit for managing asthma. All this knowledge? It's yours now. But here's the final question, the most important one. When you have a patient sitting in front of you, struggling to breathe, how are you going to use all this to make the right choice for that person? That, my friends, is where the real practice of medicine begins. Think about it.
Namaste, everyone, and a very warm welcome. I'm so glad you could all make it. Now, today we're going to tackle a topic that is just so important, not just for your exams, but for every single patient you are going to meet in your career. We are talking about the modern, intelligent way to manage bronchial asthma. So, get comfortable and let's begin.
Right, let's start with a little bit of a thought exercise. When I say the word asthma, what's the first thing that pops into your head? It's that classic picture, isn't it? The wheezing, the coughing, the desperate struggle for breath. But I want to ask you, is that the whole story? Is it really just a simple mechanical problem? You know, like the pipes in the lungs are getting a bit too narrow? Let's challenge that idea, shall we?
All right, here is our syllabus for today. First, we will get to the real funda of asthma, the actual core problem, which is inflammation. Then we'll look at our main medicines, the ones for daily defense and the ones for emergencies.
We'll also touch upon a very, very clever modern treatment, see how everything fits together in a logical treatment ladder, and finally, we will discuss something absolutely critical: how to make sure the medicine actually gets where it's supposed to go. Ready? Let's do this. Now please pay close attention because this is the single most important concept today. Asthma is not just about the airways squeezing shut. That bronchospasm? That's just the smoke. The real problem, the actual fire that's causing all the trouble, is a chronic, silent inflammation burning away deep inside the bronchial tubes. Our entire modern strategy for treatment is built around one simple idea: putting out that fire.
So, if inflammation is the villain of our story, what is our hero? Well, it has to be a powerful anti-inflammatory, right? And in the world of asthma, the undisputed champion, the absolute gold standard for any patient with persistent symptoms, is a class of drugs called inhaled corticosteroids, or ICS for short. This, my friends, is the bedrock of modern asthma management.
So, let's get this straight. Think of ICS as your daily armor. This is not a medicine you use for a sudden attack. No, this is what you take every single day to keep that internal fire, that inflammation, suppressed. The entire goal is to prevent the fire from ever flaring up. It's all about proactive control, not reactive rescue.
And what do we hope to achieve with this daily therapy? Well, number one, obviously, is to suppress that bronchial inflammation. When we do that, everything else follows. The patient's lung function improves. We can actually measure this as an increase in their peak expiratory flow rate. And because the airways are calmer, they'll find themselves reaching for that blue rescue inhaler much, much less. But the biggest win? We prevent those frightening, life-threatening acute episodes from happening in the first place.
Now, when you go into the clinics, you'll see a whole jungle of different brand names, but the actual workhorses, the active ingredients, are usually one of these three: beclomethasone, budesonide, or fluticasone. These are all brilliant corticosteroids, brilliantly designed to work locally, right there in the lungs, with very little effect on the rest of the body. And here is where the art of medicine really comes into play. It's not a one-dose-fits-all situation at all. We follow a simple mantra: start low and go slow. We always begin with a low dose. If the control isn't perfect, we step it up to medium. Only in the most difficult cases do we even consider a high dose. This process, it's called titration, and it helps us find the absolute minimum effective dose for each individual patient.
Okay, we have to talk about side effects. Because the medicine is sprayed into the throat on its way down to the lungs, some of it inevitably gets deposited there. This can cause some local mischief, a hoarse voice, a scratchy throat, or sometimes a little fungal infection we call candidiasis. But, and this is the important part, these are almost completely preventable.
And the solution is incredibly simple. 2 golden rules. Please remember this for your patients. Rule number 1, use a spacer. It's just a simple plastic chamber that attaches to the inhaler. It slows the aerosol down, allowing for a gentle inhalation, guiding the medicine deep into the lungs instead of it just hitting the back of the throat. Rule number 2, after every single use, gargle with plain water and spit it out. This simple rinse washes away any medicine left behind in the mouth. Simple, effective, essential.
Right, let's change gears. Let's talk about emergencies. What happens when that quiet, smoldering fire of chronic inflammation suddenly explodes into an out-of-control inferno? That's the severe asthma attack, or what we call status asthmaticus. In that moment, your daily fire extinguisher is not going to do the job. You need to call in the fire brigade. And that is exactly the role of systemic corticosteroids.
Let's be absolutely crystal clear about the difference here. Inhaled steroids are for long-term daily control. Systemic steroids, the tablets or injections, are for short-term emergency rescue during a crisis. One works locally, in the lungs. The other goes everywhere, throughout the entire body, to fight that massive, widespread inflammation. We only use them for a short, powerful burst, maybe 5 to 7 days, just to get the situation back under control.
Now for something really cool. Let's talk about some cutting-edge pharmacology. You see, for a very specific group of patients with severe allergic asthma, even high doses of steroids are sometimes not enough. For these patients, we now have a new type of weapon, a highly targeted smart bomb of a drug.
And this smart weapon is called omalizumab. So what on earth is it? It's what we call a monoclonal antibody. Think of it as a custom-designed guided missile. In allergic asthma, there's a molecule called IgE, which is the main culprit. It's the one that starts the whole allergic reaction. What omalizumab does is it circulates in the blood, hunts down these free-floating IgE molecules and neutralizes them before they can ever attach to mast cells and cause trouble. It's like finding and diffusing a bomb before it has a chance to explode.
But hold on, this isn't a magic bullet for every asthma patient. It is only for a very specific type, severe allergic asthma. For them, the benefits are huge. Fewer attacks, and wonderfully, they can often reduce their steroid dose. It's given as an injection. But here is the big catch. It is incredibly expensive. That's why we reserve it only for the most difficult, treatment-resistant cases where we have proven that the patient has high levels of IgE.
So, with all these different drugs, inhaled steroids, systemic steroids, smart bombs, how do we decide what to use and when? Well, we don't just guess. There is a very logical, very organized system that guides all of our decisions. We call it the stepwise approach, or the treatment ladder. Let's climb this ladder very quickly. At the very bottom, step 1 for someone with only very mild occasional symptoms, a rescue inhaler used as and when needed is enough. But the moment the asthma becomes persistent, we have to go to step 2, a regular daily low-dose ICS. If that's still not enough, we climb to step 3, where we might add another drug, a long-acting bronchodilator, or just increase the ICS dose. And for the most severe patients, we're up at steps 4 and 5, using high-dose combinations. The goal is always to use the lower step that keeps the patient well, and we're always looking for a chance to step back down.
Okay, everyone, I need your full attention for this, because this point is massive. I cannot overstate this. We can prescribe the most advanced, most expensive medicine in the world, but if the patient cannot get that medicine from the plastic device into their lungs, it is completely and utterly useless. The device and the patient's technique in using it are just as important as the drug itself.
Broadly speaking, we have two main types of inhalers. You've got the metered dose inhaler, or MDI. That's the classic puffer. It uses a propellant to shoot out a spray of medicine. The tricky part is that it requires good coordination. You have to press down and breathe in at the very same time. That's where a spacer helps so much. Then you have the dry powder inhaler, or DPI. This one has no gas. It's activated by your breath. You just take one sharp, deep breath in, and that action pulls the powder into your lungs. Which one is better? It completely depends on the patient.
1 to 5 micrometers. Just look at that number. What could possibly be so important about a measurement that small? Well, my friends, that tiny range is the secret to everything in inhalation therapy.
This range, 1 to 5 micrometers, is the absolute sweet spot for drug particles. If the particles are too big, they just crash into the back of your throat and get stuck. If they're too small, you breathe them in and then you just breathe them right back out. But in that perfect Goldilocks zone, they are just the right size to float all the way down into the small airways where they need to be. And listen to this fact. Even with a perfect technique, only about 10% of the medicine from an inhaler actually reaches the lungs. 10%! That means 90% is wasted. That is why technique is so important. So, after all of this pharmacology, all this talk of drugs and particles and devices, let's just zoom out for a second and remember why we're doing this. It all comes down to the patient. Our goals are simple. We want to relieve their daily symptoms, we want to prevent future attacks, and we want to minimize as much as possible their need to ever go to a hospital emergency room because of their asthma.
And I'll leave you with this final thought to ponder. You know, it wasn't so long ago that our profession was just playing defense, mostly just treating asthma attacks after they happened. But now, with our understanding of inflammation and this incredible toolbox of medications, we're playing a completely different game. The goal has shifted. It's no longer just about treating asthma. The real question for all of us, for your generation of doctors, is this: can we use these tools effectively to achieve true control? That's the challenge. Thank you.